Sometimes what happens to a pelvic floor is that it's a little bit too active. So its resting place or resting tone that we like, that's what we usually like to call it. It's a little bit higher.
So that kind of brings us to the question of the too tight versus too loose, which is the way a lot of people understand pelvic floor dysfunction. Maybe you can explain that a little more to us and the implications of either direction.
First of all, let me just say, I have to admit, I have a little bit of a problem with the term too loose, because I really feel like, first of all, your pelvic floor can either be hyperactive, meaning that it's working a bit too much, it's working a little bit more than it should, or it could be a little bit weak. And if it's weak, it can still work. I feel like the whole idea around the term too loose, it's just pretty much holding on to the whole idea is that a woman should be a certain size down there, and that's a really horrible thing, because I think it put a lot of pressure in my women, particularly after birth. So I do feel like if we can all stop talking about the too loose, that would be great. But why sorry, can you remind me again?
So the difference between the two, but one of the things that people often ask is, can your pelvic floor be too tight at the same time as being too weak?
Yeah. Okay. So that's an interesting question. So you can have a pelvic floor that is too active, and because it's too active, it's already at end of range. So if we forget about the pelvic floor a little bit, and we come here to my bicep, for instance. So a pelvic, if we imagine that my bicep can contract and can relax. Sometimes what happens to a pelvic floor is that it's a little bit too active. So its resting place or resting tone that we like, that's what we usually like to call it, it's a little bit higher. That means that your pelvic floor, when it's not doing anything, it's already a little bit almost at the end of range. So I want you to imagine, if your bicep is like this, you actually don't have as much strength because you're already close to end of range. So it's pretty much what happens to our pelvic floor. So it can be weak, but it's actually not weak. It's not weak, it's at the end of range. So you cannot produce as much strength here. The reason why we leak when our pelvic floor is a little bit more hyperactive is usually more linked with fatigue. As you can imagine, like if you forget the pelvic floor and you think about my hand, I want to just do an experiment all with me, and just, this is what I ask my patients, like hold and squeeze your hand with all the might you can, and keep on squeezing, keep on squeezing, keep on squeezing. Well, first of all, even if you didn't have any pain on your hand, by now it's already burning a little bit. So that's why a pelvic floor that's a little bit more hyperactive has a bigger tendency of being a little bit more painful. But another thing is, by the end of an hour, the amount of strength that I would have to do to open my fingers, it would be a lot less, because there is such thing as fatigue. And this is why sometimes some pelvic floors that are a little bit hyperactive, they can actually contribute for leaking, because it's just fatigued, because it's working always more than it should be. And then there is a whole bunch of other things. Like, we also know that leaking, it doesn't only come from the pelvic floor, it can also come from the bladder. And if we have a history of repeated UTIs, it can actually be that your bladder is activating a little bit more. And if that's the case, you add the bladder that is activating a lot and the urethra that pelvic floor is pretty much like at the edge of fatigue, and you will leak.
That's also another question that came up, is if it's the problem with the weakness or the strength of the bladder itself, can pelvic floor therapy help with that, or does something else need to be done?
So yeah, definitely. So if it's for instance, for overactive bladder, pelvic floor physiotherapy, and when I say pelvic floor is physiotherapy, I am not saying pelvic floor muscle exercises or Kegel. So I think this is important to say. We have a pretty good success rate with overactive bladders. So so we have a big range of things that we can do. So to make it simple, what I tell my patients is the only reason why we don't leak is because, like, so if you imagine like this is a little balloon full of water, the only reason why we don't leak is usually because this pressure to close, it's bigger than the pressure that is at the top. So if the pressure here is bigger and we have a good pelvic floor to close, we're fine. However, if this is squeezing so much, there is only so much that this can do that it will give up at a certain point. So we always need to understand which one is the problem. So sometimes I see that some people think it's an overactive bladder when it's actually prolapse. Sometimes I feel like some people actually have overactive bladder and they were diagnosed with other things. So it's always important to understand what is the driver. And this is why I feel that pelvic floor physiotherapy needs to be seen beyond Kegel, because if you keep on looking only at Kegel, people that have a pelvic floor that is already increased, like in terms of activity, and we don't work with this coordination of being able to completely relax and being able to completely contract when you need, we'll just be a little bit stuck.
That is a question, because a lot of people are told by physical therapists of one kind or another that Kegels will help, but we've also been told that they're not right for everybody. Are there exercises that everyone can do on a daily basis that will benefit, or is it always important to see a qualified therapist first?
So I will say what I tell my patients. So even if I tell you all that avocados is the best thing in the world, not everyone likes avocados. Not everyone will be healthy with avocados. So there are some people that are allergic to avocados. There are some people that don't digest avocados. There are some people that simply will never eat avocados. And I do feel like it's a little bit like that in health in general. There is not one thing that will work for everyone. So we like talking about pelvic floor exercises and Kegel because and we hear a lot about that in media in general, because one of the biggest I feel like one of the biggest conditions that we treat in pelvic floor physiotherapy is in urinary incontinence, stress urinary incontinence. And for stress urinary incontinence, definitely pelvic floor muscle exercises are the first line treatment, and the one that we have a lot of evidence to show that. But whenever we talk about things like pain during intercourse, pelvic pain, and bladder pain syndrome or recurrent UTIs, the problem is very different. So even now, I love that you asked this question, because I think it was last week, it came also in the news that in the UK, they were going to ask little girls to start doing their pelvic floor exercises. And I do have it's hard for me to just imagine that all the girls will actually do it correctly, because we know that 20% of people do it incorrectly as well. And my other concern with that is, how will you teach someone to do it? Will it be based on body awareness? And that would be a really positive thing, because I do think we need to have body positivity with our pelvic floor as well. Or will it be towards preventing a problem and creating fear around leaking? Because if that's the case, I would say that the UK is only feeding and giving me a Porsche in the future, pretty much just making sure that I'll have work forever. Because I'm afraid that this will actually create another problem, which is people will start activating the pelvic floor too much without knowing too much what to do. Because I do feel like when we think about Kegel, what we think about is squeeze and squeeze and squeeze and squeeze. And that's not how the pelvic floor works. I like to talk about the pelvic floor like it's an arm. I need to pick up things with my arm to bring them to my mouth, but I also need to go out and pick up the food. It's the same. You need to be able to contract. You need to be able to relax at will. So if we only focus on squeezing, you're going to have problems with relaxing after. So I would say highly recommend an assessment for you to know where you need to improve, rather than expecting that it's the same thing for everyone.
Yeah, I think that's really good advice. Because we do get that question a lot about the link between recurrent UTIs and pelvic floor disorder. Could it be that the pelvic floor issue caused the UTIs in the first place, or could the recurrent UTIs actually lead to hypertonic pelvic floor, for instance? Can you kind of talk about the direction that might flow in?
It's a catch-22 in a way, because it's hard for me to really imagine that. Well, definitely, let us imagine like we had trauma in the pelvic floor, and for any reason, it could be either abuse, or it could be simply like we had a little cut around the vaginal canal. So remember, any pain around the area, like one UTI, and let us imagine. So that pelvic floor could become a little bit hyperactive as a way, or a little bit more active or tighter as a way to protect itself from pain. So one thing I like saying is, if we think this is a needle, And if my hand gets prickled on a needle, my hand doesn't stay there and think, oh, this kind of hurts. No, it usually just runs away from it straight away to protect itself from the pain. And our pelvic floor cannot run away from what it is. So what it does is usually whatever it can, which is similar to what I did with the hand, which was protect and contract. So if there is any pain around the pelvic floor and your pelvic floor gets a little bit tighter, usually remember that the pelvic floor has to be able to contract to stop us from leaking, but it also has to be able to relax for all the wee to go out. So if your pelvic floor loses that ability to completely and fully relax, to allow the wee to completely come out, we definitely have a higher chance of developing a UTI. We also know if we have a lot of UTIs, for instance, let us imagine that like your bladder started reacting a lot, and now you got like one UTI after another. It's quite common, like if we have like an infection and then we ended up having a yeast infection and then it develops again as we have caniston. So if we were really unlucky and we had a series of repeated episodes of UTI, that in itself can, because your bladder is always activating and always just irritated, remember that the only reason why we don't leak when we are just talking right here, right now, it's because we have a pelvic floor that is doing enough, just enough that it needs, so that our bladder doesn't really pushes and opens our urethra. So your pelvic floor and your urethra are doing its job and are closing the urethra to make sure we're not leaking right now. So if we have like a bladder that is always contracting, and we know it's not socially accepted to leak, well, the only thing that can stop us from leaking is our pelvic floor. So if you have a bladder that is always activating, your pelvic floor will have to contract more. So repeated episodes of UTI can definitely lead into problems with your pelvic floor. However, I also need to talk about bowel, because I do think we only talk about bladder and pelvic floor and we often forget about bowel. The same happens if you have a big bout of diarrhea. The only reason why we don't lose and we don't lose stools when we're walking is because we have a pelvic floor and an external sphincter that is closing the hose in a way. So if let us imagine more than just a UTI, repeated UTIs, we also have irritable bowel syndrome and repeated episodes of diarrhea, your pelvic floor will also have to squeeze and hold. So we need to that's why I feel like pelvic floor physiotherapists are so good, because we try to really go through the whole systems and try to understand, okay, what is feeding onto this loop and how can we break it? Because if we have repeated UTIs and we keep on only looking about the bladder and the pelvic floor, we may be missing a really important thing when we talk about bowel, and also another thing that probably you'd like to talk, which is menstrual health.
A lot of people do report that they have digestive issues alongside recurrent UTI, so that's definitely a topic. One of the questions that comes up is if the infection has cleared and you're still experiencing symptoms like burning around the urethra, could that be caused by an issue with the pelvic floor that has been triggered by the frequent UTIs, or do you think that's still possibly a sign of infection?
It's a hard question, and I love the question because it is not a simple answer to that. And the reason why I'm saying this is because we have now some new research coming out. It's also saying that sometimes it's really an infection, but that it's so low that current tests are not as sensitive all the time. So even with some clear tests, sometimes we ask for urine cultures. So I think it's important for people to also know there is a big difference between an MSU and a urine culture. And when you have doubts whether your test came as a false negative, ask for a urine culture more than an MSU. What I would probably say is, I know I should not probably say this, but the fact is, if you have doubts and you want to check it again, make sure you actually advocate for yourself. Because what sometimes happens is that the infection is so low that they're not being able to check. And another thing that I always tell my people is make sure that instead of having a lot of water and doing the urine test during the day, No, have the first urine of the day, because that has that's the urine that has been in your bladder for longer. So the concentration of organisms will be a lot bigger, rather instead of in comparison to all the water you have been having during the day and diluting it. So usually the first urine is the best one. And if you have questions, just make sure you advocate for yourself. So that's one. So it can actually be an infection. Your pelvic floor though can also become sensitized. So I feel like we do need to also see the pelvic floor as not only something that is there. So a good way to see it is, like, imagine, have you ever had like a paper cut that it was like that you almost feel like it's the pain is not only here, but actually starts radiating a little bit.
Yeah.
So it almost feels like it's a lot bigger than it actually is. So sometimes your pelvic floor and your body can start we can feel referred pain, and what we call I like calling it a lingering pain. So if that's the case, your pelvic floor can definitely be holding on around the area to protect itself, which can give you a burning area around the urethra. You can also have a reaction to the antibiotics. So we know that one of the biggest problems we have from having a lot of antibiotics is developing a yeast infection. So you can also develop a yeast infection, and often yeast infection can also be located around the urethra. So you can feel that reaction as well. So it's hard. There's not an easy answer for that. So it can still be an infection. So if you feel it's an infection and you're not 100% sure, double check it. If you see as well that there is redness, it could be that you're having also a skin condition. So make sure that your gynecologist also checks for that. If everything has been cleared, your pelvic floor can definitely be another reason.